So welcome everybody to this Healthwatch Oxfordshire webinar. We're really pleased to be focusing on this important topic that's come out of the NHS 10-year plan around the future of healthcare and neighbourhood health. We're welcoming Ansaf Azhar, Director of Public Health, Michelle Brennan, Chair of the GP Alliance, and then we've got others in attendance from Bob Icey Integrated Care Board and Laura Price, really welcome, from Oxfordshire Community Voluntary Action. So we'll welcome Ansaf and we'll hand over to you to share your slides.
Thank you, Veronica. I'm just going to share my slides. Assume everyone can hear me all right. Can I check? Can people see my slides?
Yeah, we can.
Excellent, excellent. Lots of thumbs up. Brilliant. So I'm Ansaf Azhar, Director of Public Health for Oxfordshire, and I'm really pleased to be able to open this webinar. I think it's really timely to talk about the Neighbourhood Health Plan. Please do see me as setting the context to what is to come after me, which is Michelle Brennan, which will give a little bit more detail around some of the Neighbourhood Health Plan development. But I'm going to set the context at a kind of population level, at Oxfordshire level, what that means. So as Veronica said, we've got the NHS 10-year plan. The NHS 10-year plan very much is focused on the three shifts that you would have heard of, which is treatment to prevention, hospital to community, and analog to digital. Initially, I think it's fair to say the neighbourhood health plans were very much focused on, quite rightly so, to move from hospital to community. How can we move things more into community and deliver our clinical services in an effective way in the community? The initial thinking was to have some plans ready by December, but there's been lots of conversation since then that we should not only just talk about clinical plans, we should also think about prevention and the needs of the population as a whole, and the role of voluntary sector and other partners can play, local government sectors and so on can play in delivering the neighbourhood health plan in that kind of holistic sense. So the aim is to feed that back into Health and Wellbeing Board, and Health and Wellbeing Board becoming the accountable body to oversee the overall plan. That was meant to come in December. Now it's been delayed till April, and I think it may well be delayed a little bit further, which perfect in a sense that it gives us the opportunity to really embed the whole of the needs of the Oxfordshire population and think prevention, think inequality, I think the wider determinants of health that really impacts on the health and well-being of our population. So as well as delivering the clinical element, delivering that whole holistic element, it gives us a great opportunity to do that. So I'm going to start this presentation by talking about a little bit about our Health and Wellbeing Board strategy. In Oxfordshire, in 2024, we developed a health and wellbeing strategy across the 4 domains: start well, live well, age well, building blocks. And these 4 domains had 10 priorities across that. And as a partnership, we all agreed to those 10 priorities. From start well, talking about best start in life; from live well, talking about healthy people and healthy places; age well, maintaining independence; and building blocks, things like financial well-being, healthy homes, and so on, which are really important to health and well-being. So from my perspective, the Neighbourhood Health Plan is a delivery vehicle for this Health and Wellbeing Board strategy that we have agreed. And let me be clear, the Health and Wellbeing strategy is completely impartial. It has all partners signed up to this, and it's developed from something called the Joint Strategic Needs Assessment. The Joint Strategic Needs Assessment looks at the data and the needs across the whole of Oxfordshire communities in a very impartial way, which then informs this health and wellbeing strategy that you have in front of us. So it's very much evidence-led and data-led approach. And actually, it would be absolutely fantastic if you have a neighbourhood health plan that is aligned to this Health and Wellbeing Board strategy, which we all already signed up to, that is also data-led, impartial, and needs-led. So I think we have a great opportunity to align our health and wellbeing strategy with the neighbourhood health plan. We also know there are other drivers, there are other things that actually drives the neighbourhood health plan. We also know that Oxfordshire is a marmot place. We've spoken about it quite passionately in various events. We are not just a marmot place. We're quite a unique marmot place in the sense that we have genuine ownership across the whole of the system for becoming marmot place. We've got great universities at our doorstep, world-leading universities at our doorstep, who's aligned to deliver the marmot place and to do research in that space. We've got a real mix of urban and rural inequality. And I think it's great that we are a marmot place with that level of ownership, and we prioritize on 3 areas, which is best start in life, a healthy standard of living, healthy homes, and employment and workplace agenda. So these are the 3 things as a marmot place we are actually focusing on from the 8 principles of marmot. And there's a question about how does that then align with the neighbourhood health plan that we develop. It's really important because we know neighbourhood health plan has to deliver the clinical element, and that is right. It does need to deliver that for the NHS, but we also know that all the things that drives that clinical demand comes from the social and the wider determinant elements, and we need to tackle the drivers of those ill health, not just manage ill health, if that makes sense. So I think we have a great opportunity to do exactly that through aligning our health and wellbeing strategy and aligning our marketplace ambitions. So I don't need to tell you this. You've seen this many times. Some of the things I'm saying, some of you would have seen this quite a few times. But just to remind, Oxfordshire as a whole is a very affluent area. Now, you can't read the stuff on the left-hand side. It's very small, but they are basically health and well-being indicators from long-term illnesses, emergency hospital admissions, to childhood obesity and things like that. So you got all those indicators on your left-hand side. What you can see there on the right-hand side is, if you look at Oxfordshire as a whole, we are green. Everything is green, which means we are much better than national average as a whole. But if I repeat those same indicators for our 10 areas of deprivation, the picture completely changes. They all turn red. In other words, they're worse than national average. So if you want to lift Oxfordshire's health and well-being as a whole, we need to disproportionately focus in our most deprived areas. Now, we also know that we've done that for the last 3 or 4 years, and our recent IMD deprivation data has actually shown some really positive news. It shows that some of our deprivation in these areas have started to close the gap. We still have a very long way to go, so we should be encouraged by that and go further and faster in the things that we are doing. But it is a great news that we are starting to see, and that data has just landed. And my next year's Director of Public Health Annual Report is going to be all talking about what the work we have as a system, all of us have done over the last 5 years, and how we've, as a system, we've worked together to achieve that. Now, we have an opportunity to look forward and think about how Neighbourhood Health Plan will be the forum in which we take that forward, which is really exciting. Just to elaborate a little bit further on this, so if I look at any indicators for that matter, so you've got obesity here, children and in children at reception here, you can see the red line is Oxfordshire, the blue line, or the black line, is England, and you can see Oxfordshire is much better than England, and it's lower. The obesity prevalence is lower. Now, if you break it down to districts, which are the coloured bars, you can see there's not much of a difference there. There's a little bit of a difference, but the real difference comes in when we start to look at community level, Banbury Roscote, Blackpool East, and so on. So, sorry, I'm just going over. So that's where the real difference comes from. And that's why we wanted to take that kind of a community-led approach to doing things. Even looking at district level, city level is not going to be sufficient. It's not going to be able to pick that up. So we have an opportunity to really go down to those community levels. And that doesn't just apply to these indicators. I can repeat this to other indicators as well. This is emergency hospital admissions from coronary heart disease. You can see the variation. England's right at the top. You can see Oxfordshire is much better than England in terms of emergency hospital admissions. But if you go down to individual wards and individual communities, you can see the stark difference in that. And then the same with good level of development at the age of 5 years. On the very right-hand side, you see those areas that are particularly falling behind. in the good level of development, and they're often the areas of deprived areas. So this is why one of the things I want to do is going forward is to expand that community profile approach we started across the whole of Oxfordshire, because every area will have hidden inequalities that we are not aware of, and we need to start measuring it and learning from it and taking actions like we have done with the 10 areas as well. So just to I always use this triangle to sum up where we are. So we all know that illness is caused by both what's called modifiable and unmodifiable risk factors, right? Unmodifiable risk factors are things like your genetics, these things you can't do anything about. Modifiable risk factors are things that you can do something about. And if you ask the question, why do we see high levels of illnesses, whether it's blood pressure, whether it's heart disease, whether it's cancer, why do we see high levels of illnesses in our areas of deprivation? It then goes down to the second theme, lifestyle. We will see huge amount of these what I call modifiable risk factors, high levels of poor lifestyles, whether it's physical inactivity, whether it's eating unhealthy foods, whether it's drinking, smoking, things like that can play a significant role in disproportionately seeing high levels of illness. So we spent a good part of the late 90s and early 2000s telling people we need to educate them. And we did that quite a lot. But now we know education doesn't on its own work. People know what are the good lifestyle and bad lifestyle. So then you ask the question, why do people have these poor lifestyle? Then mental well-being is a big driver for that. Mental well-being, poor resilience, loneliness, social isolation, these things can drive poor lifestyle behaviors. Then if you ask the question, what does cause poor mental well-being? It boils down to your social and wider determinants issues, from housing, employment, education, poverty, financial well-being. All these things has a key impact. Now, the neighbourhood health plan absolutely has to deliver on the illness model right at the top on the clinical piece. But what about those 3 domains at the bottom? We have an opportunity to influence through the neighbourhood health and align our services appropriately. So we influence on all of those 4 domains. In terms of return, it takes longer to have impact. Some of them are quick wins as you go down the triangle in mental health, but it does make some structural changes to drivers of ill health. And that's what we need to do if you're thinking about the future and if you're thinking about demand management and so on. So I always like that triangle. I always use in that 4 themes. And the important thing is that we take proportionate action in a preventative way across those 4 themes. And then I'm going to finish off with this slide. And it probably is a slide that encompasses everything I've said so far. And that is the design principles we should consider, therefore, in developing the neighbourhood health plan, alongside with the clinical element that we have to deliver. Now, the NHS has got 5 or 6 criteria that they have to deliver against, which is correct. I think we do need to follow that. But in addition to that, I think these design principles, I've got 5 design principles, which I think we should always look to fulfill. And then the Health and Wellbeing Board should use that and the board to hold to account. And these are, the first one is, I talked about the Joint Strategic Needs Assessment being that impartial body of evidence that gives the needs of the population, that influences the health and wellbeing strategy. So it needs to be evidence-based, needs-led, influenced by Joint Strategic Needs Assessment, and have a population health approach. Secondly, no surprises there, when we use that evidence, we need to have a proportionate universalism approach, because here we have significant inequality in Oxfordshire. Doing the same thing across the whole of Oxfordshire will not work, will widen inequality. So we need that proportional universalism approach when we see that data. And that needs to be, that design principle need to be embedded across neighbourhood health plans. Thirdly, everything that we do, we need to think about what is the prevention focused and early intervention approach to it. How can we, links back to the population health management approach. What can we do to reduce that demand? How can we act early? Fourthly, it's really important once we do these things, whatever solution we do, we co-produce those solutions with our communities. The community profile approach has shown that. The community profile work that we did not only got the data and intelligence for those communities, but it mapped the assets that are available to the community, produced solutions with the community, and that means the community owned it. There's more engagement from the communities because the solutions are produced with them. And then last but not least, in doing that, we have to enhance our working with the communities and the voluntary sector to get that reach. So evidence-led, tackling inequality, early intervention and prevention, co-production, close working with the voluntary sector. These are the 5 design principles that we want to help influence the neighbourhood health plans. And nationally, these design principles are also fed back nationally in some form or the other to influence the whole neighbourhood health plan agenda. So that hopefully will be a nice segue for me to hand over to Michelle. I'll take my slides down and then I'm sure after Michelle's done her bit, we can open up for questions. Thank you.
Thanks, Ansaf. I'll wait for you to stop sharing and then I'll put my slides.
That should have come off now, Michelle.
Okay, great. Go back. Right, is everyone able to see my slides?
Yeah.
Yep, are they all there? That's great. Brilliant. So thanks so much, Ansaf. As Veronica's already said, my name's Michelle Brennan. I'm a GP. I chair the Oxfordshire GP Leadership Group, and I also co-chair the new Primary Care and Community Board, which has been set up to oversee the implementation of neighbourhood health and care across Oxfordshire. And I co-chair that with Grant MacDonald, who's the CEO of Oxford Health, the mental health and community trust in Oxfordshire. So basically, I've come here today to talk to you about Oxfordshire's approach to neighbourhood health and care. And I just want to emphasise that we're really at the start of this journey. And so it's really good to come and talk to you, at the early stages. And in essence, neighbourhood health and care is about getting appropriate care as close to home as possible. And I think we need to be really clear about this, as Ansaf's already said. This approach is much broader than just the NHS and social care. It involves working with, local residents, communities, voluntary care, faith, and social enterprise organisations. So it's asking us to work much more broadly and in a different way. Go on to the next slide. So I thought I would frame this. I thought I'd start with just looking back as to where we've got to where we are, then talking a bit about the present, and then looking at the direction of travel. So some of you may have read when the new government came into power, they asked Lord Darcy to do a rapid review of the NHS. And what that report highlighted, that almost every policy over the last 20 years, and arguably longer, has highlighted the need for the so-called left shift. And by the left shift, we mean moving towards a more proactive and preventative model of health and care, rather than the reactive one that we often see today. However, almost every policy and commissioning and a multitude of other factors have resulted in us actually having a right drift. So although every policy has had a direction of travel of left shift, we've actually gone in the opposite direction. And if you look at the way the resources, both in terms of workforce and finances, are distributed across the integrated care system of Bob, and this is no different from across the whole of the country, the majority of the resources sit within the acute trusts. And as many of you will be aware, if you look at NHS activity data, the majority of activity already occurs in the community by means of GP appointments and community services. So we need to be cognizant of the fact that this isn't easy. And if it was easy, we would have done it already. And I think it's also important to, we also have to think about, so why are we bothering? I think you always need to ask the why. And some of you may have already seen this slide. This slide was from the primary care strategy that was released I think about 18 months ago, a couple of years ago now, which shows that if we continue on the current trajectory, demand is going to continue to exceed capacity. So we need to look to see how we can do things differently. And I think as Ansaf has already alluded to, what we need to be really aware of is that actually health and care is only responsible for 20% of a person's well-being. The other 80% is determined by the wider determinants of health. So we need to think about diet and exercise, smoking, education, employment. It's much broader than just health and care. And I think, when people come through my door into a healthcare setting, I immediately medicalise you. Now, you might well have a medical need, but often the drivers of that medical need are due to the wider determinants of health. And other areas that have already implemented a neighbourhood health and care approach are trying to co-locate services, so including medical, along with the voluntary care sector, and also social care, so that they can offer a much more holistic approach to people's needs. So in the summer, as many of you will have seen, and some of you may be involved in providing part of the consultation for the 10-year plan, Fit for the Future, was released. And a real theme of this was the development of neighbourhood health and care. And that was to be enabled by the 3 shifts: hospital to community, analogue to digital, and sickness to prevention. Now, I think we need to highlight that in Oxfordshire, we are already doing a number of these things. So in terms of hospital to community, we already have a community gynae service, which is provided by one of the GP federations. We have hospice at home services, hospital at home. With regards analogue to digital, more and more people who are able to use the NHS app to order prescriptions. You can do online requests via the NHS app and also have access to your records. And by more people using digital tools, that frees up telephones and other channels to enable people who aren't digitally enabled to access services. Also, in some surgeries across Oxfordshire, you will have seen that people are starting to use AI in the form of ambient voice technology, where people are recording their consultations. And again, sickness to prevention. For a long time, we've had screening programs, vaccination programs. But I think, if you look at the data, and it speaks to what Ansaf has already said, we need to understand why people aren't taking up these programs and how we can improve uptake to get more upstream. So within the 10-year plan, there was a number of documents referenced about neighbourhood health. So there was about the model neighbourhood framework, which I'll come on to talk about a bit more in a minute, and also about a neighbourhood planning framework. There was also talk about model neighbourhood health centres, and it seemed to give the impression that there was going to be a neighbourhood health centre within every neighbourhood. Now, I think we already have GP practices, but I think as to having a brand new neighbourhood health centre, that's not realistic. And if you saw in the budget, I think there's going to be funding for 250 new neighbourhood health centres, but the majority of these will be a refurbishment of existing buildings, and only a very small number will actually be new buildings. And the places that these are likely to be sited are areas of high deprivation. So I think we just need to be realistic about these new neighbourhood health centres. But also, within these neighbourhood health centres, there will be guidance about and suggested models about which services should be co-located within these. There was also reference to 3 new contracts. So an integrated health organisation, which would effectively hold the population health budget for the whole of an area. The other contracts are a multi-neighbourhood provider that would look after a population of about 250,000, and then single neighbourhood provider contracts, which would look after a population of about 50,000. Now, we're still waiting for further information on these, and understandably, these have caused some concern from providers about how they will fit into this new structure, particularly amongst GP practices. Now, we were advised that all these new documentations, as Ansaf has said, would be here in October, then November, then December, then we were hoping in the new year, and now we're being told February. So the planning, as Ansaf has already said, is we need to produce an interim plan for neighbourhood health and care in Oxfordshire by beginning of April, but it's looking like that may be delayed. So I just wanted to talk about the local context, as we already know. As Ansaf said, we have an increasing and ageing population. Oxfordshire is the most rural county within the southeast, and we also have increasing health inequalities. We also have to acknowledge, as far as workforce is concerned, that it's an expensive place to live. Now, when we started on this journey of neighbourhood health and care, we've been working with a Professor, Malcolm McCulloch at Oxford University, who's a professor of engineering, but also an expert in system transformation. And he did a thematic analysis of all the feedback across the system in Oxfordshire. And, there was recurring themes. What we heard was that when people get into a service, they usually rate it very highly and also rate the staff very highly. But what also we heard consistently was that we're very organisationally focused, the system's quite fragmented and difficult to navigate, and also as people move between providers and organisations, that can be quite difficult for people and they can fall between providers. So the current position that we're at with neighbourhood health and care is we've established a new board called the Primary Care and Community Board, which we have cross-sector representation on. We've got GPs there, people from community health, public health, the local authority. We've also got people with lived experience on the board as well, which is really, really helpful. And also, just to start those conversations across Oxfordshire, we've divided Oxfordshire up into 4 areas. Now, I just want to emphasise, these are not the neighbourhood geographies. They're just simply areas so that we can start to bring people together into smaller groups, and we're calling them sort of planning units. And they've been divided north, city, south and west. But as I say, they are not the geographies. They're very simply for us to sort of start some early conversations. So as Ansaf has already said, the model neighbourhood, we have seen an early draft of that, although we understand that that's still going through consultation. But what we understand at the moment we're going to be asked to do is we're going to ask to start with looking at geographies. Now, as many of you will know, we're very good at thinking about geographies within the NHS. We've had PCTs, CCGs, ICBs, new ICBs, primary care networks, and now we've got neighbourhoods. And a neighbourhood of 50,000 plus is very different to probably what you or I think as a neighbourhood. I think it's my road, my next door neighbour. So I think neighbourhood is perhaps an unfortunate term, but I think it's one that we have to work with. So at the moment, we're sort of considering how the neighbourhoods will align within Oxfordshire. And then the next step is to look at access to care, particularly general practice, but also, broader primary care, so community pharmacy, who now offers pharmacy first, optometry, dentistry, and also there's a number of services that people can self-refer. And then looking at the interface between different organisations, particularly primary and secondary care, and how we can ensure that that's more seamless for people. And then looking within the neighbourhoods at priority groups that, as we can come together within that neighbourhood to support them in a more integrated way. And we've also been asked to look at developing a more seamless, integrated urgent care pathway. And finally, looking at outpatients. So currently, the traditional model is you'll come and see your GP, who'll try and look after you to the best of their ability, and then refer you on to secondary care. Now, many of you will have experienced something called advice and guidance, where the GPs will seek advice from the specialist rather than actually making a referral. And also, traditionally, people have been followed up in secondary care. A lot of that will be now initiated when it's needed by people, rather than you've been giving a set time to be seen. So it's just to highlight that this is a sort of whole system change, not just at one level. And then, as Ansaf has said, we are more and more going to be taking a population health management approach. And within Oxfordshire, we're going to be using the Johns Hopkins segmentation. Now, many of you may be familiar with this within general practice. More and more practices are using this to understand the needs of their practice population. And what this does is it segments people into patient need groups, lower needs, moderate, and then right up into higher needs and the red segment. So if you look at the population of Oxfordshire, as Ansaf's already said, the good news is the majority of people are green. But so neighbourhood health and care, the model we're building, is really looking at the 20% of people who are in the amber and red group. So this is the emerging neighbourhood structure that actually sort of gives you a visual representation of what I've been talking about. So it's important to say that the majority of people will continue to get the majority of their care from their GP, broader primary care, and also community care. And it's the 20% of people with more complex needs, so people as they're coming towards the end of their life, people with lots of different illnesses, that will benefit the most, we hope, from neighbourhood health and care and a more coordinated approach. And then going further up up the scale, we've talked a little bit about multi-neighbourhoods, and then looking at the hospitals. Now, of course, we're not going to be getting any new hospitals, but the idea of this model is that people will only go to the hospital if that's appropriate for you, and the majority of your care will be done in the community. And so that will involve a different approach from the hospitals, where they will, people who work in the hospitals, either virtually or physically, will be coming out in the community to support the needs of local people. And then I'll just, as I finish, I just wanted to leave you with the vision statement that we developed over the summer through cross-sector workshops that we had. So thank you for listening, and happy to take any questions. Thank you.
Thank you very much. I wondered if, before we start questions, whether Laura would like to add something quickly before we start, or we can leave it otherwise. Laura?
Yeah, thanks, Veronica. I suppose just very quickly, I think just emphasising that message that it's about a whole collaborative system. So right down from individuals and communities up to kind of our acute hospital, and really pleased to see in the draft design principles the fact that community input and lived experience, and the community and voluntary sector is already there in the design principles. So just really keen to follow that through, really, and today is part of doing that.
Thank you. I will just lead on with a question that's in the chat before we open up to wider questions. Maggie Winters from one of the PPGs has asked, how can we involve PPGs, some who are understandably more focused on very local health services, rather than prevention in a holistic way? The huge appetite from PPGs to start engaging more with this agenda.
And that's great news. And I think if people that have read the 10-year plan will know that another key theme was about co-design and co-producing new pathways along with local residents who use them. So certainly as we come down into the neighbourhoods, once we've defined the geographies, we'll certainly be trying to bring people together within that community to start discussions and look at both quantitative data but also qualitative data about what's important and what matters to the people that live there. But also, I just want to highlight that we do also have people with lived experience sitting on the Primary Care and Community Board who are also helping to develop the plans as well. And that's something really new for all of us that, we're sort of trying to, evolve as we go.
I can't see any questions at the moment. Has anyone got a question they'd like to ask? I would like to just ask a question quickly, which is, Michelle or Ansaf, could you give an example of what difference this will make to an ordinary person living in one of the communities? What difference might they see? Can you give an example of that?
So I suppose in Alderhay, what they found is they noticed that from their data, a lot of children were presenting to the hospital with respiratory illnesses. And what they have done is that they have gone into the community and spoke to the parents of the children to try and understand, how they could support more care in the community. And what they've done is so some of it was about not understanding how to access services, not having English as your first language. And so within particular communities, they've trained up sort of health advocates, I suppose, or community leaders who are able to support parents to self-care and self-manage. And also they've been working with the local authority and people who are in poor housing. They've been giving sort of dehumidifiers and things to put in houses to try and help the children who've got quite severe respiratory illness.
Mehdi, would you like to ask your question?
Can I just carry on? Yeah.
Sorry, Ansaf, did you want to add something quickly?
I was just going to say that I visited a scheme called Better Housing, Better Health, and actually, when which is commissioned in Oxfordshire, and when I go to this, and I did visit myself, and you can see when you go there, people living with COPD conditions, respiratory conditions, and often living in mouldy houses actually needs addressing. So we often see in the hospitals where we fix people therapeutically, clinically, send them back home to the same conditions that they were living in that made them ill in the first place. And actually, I saw the real value in one example was we went to a house which is mouldy, patient was suffering from COPD. They had an oxygen cylinder right next to it. They had packs of cigarettes, smoking cigarettes. So in one visit, we were able to address housing issues. We were able to address refer them to stop smoking services, align their COPD clinics, making sure they are attending the appointments necessary. That's all done in one. And I think what I would see is that neighbourhood health will be able to hopefully scale that type of approach more. Not necessarily in that way, but in a way that reflects the community.
Thank you. Mehdi, would you like to come in with your question?
Yes, thank you, Veronica. Uh, I'm going to ask, if I may, a general question. It's something that I've just discovered today. Perhaps I've been not quite alert. I'm just coming from hot-footed, if you like, from an event at the Institute for Government. And there were very high-profile people presenting there, including Patricia Hewitt, the ex-Secretary of State for Health. I was aware that the 10-year plan was about abolishment of the NHS England, also reduction of the number of ICBs too. But what I discovered today, to my amazement, is about the creation of a new Department of Health and Social Care. Is a quite a significant and radical mission. My question is, how much what we heard from Ansaf and from Michelle actually is dependent on how the center will be running, how the new Department of Health and Social Care will be running. Because in my lifetime, I've seen 4 or 5 attempts to actually recreate the Department of Health and now Health and Social Care. And I'm a bit surprised that in any of your presentations, there was no mention of the creation of the new department.
Thank you. Ansaf?
Yeah, I can kick this off. So 2 things, and then Michelle, feel free to come in. The first thing is I don't think there's a new Department of Health being created, so I can clearly say that I haven't heard of that. It's simply a matter of there were lots of overlap between DHSC and NHS England, and the proposal is to amalgamate the two. That doesn't necessarily mean it's a new organization. It means that the functions are going to sit and complement under the DHSC. So that's the first thing to say. Unless I'm mistaken, then I'm very happy to pick that up. The second thing is a more of a broader point. I've now worked in the health and care system for nearly 25 years, and I've seen a change in healthcare systems. Local government doesn't change very often, but healthcare systems change every 5 years roughly. There is a change, and I think despite those changes over the last 2 decades, we have seen great things that are happening locally. So what we want to do is to create a system locally that is future-proof for future changes that come about. Whether it's neighbourhood health plans, whether it's another change in the future, whether it's ICBs getting big or smaller, ultimately by following the design principles that we've done locally and following the things that Michelle just talked about, we were able to align that with whatever changes that comes in the future. And I think whenever I see resilient local systems, that's what these are the design principles that I see. Whatever system we have in place, ultimately, if you have an evidence-led, data-led approach that tackles inequality, works with the community, strengthens voluntary sector, treat patients in a holistic way, it doesn't matter what national things. It's about, we might have to rejig a little bit how we organize ourselves, but those principles will stay alive and will deliver outcomes for our residents.
Thank you. And there's a question about local government reorganisation. I think the same would apply to the intention there.
Yes, I can come in on that.
Yes.
I think any plan that we make, there's so much moving going on. As Ansaf's already you mentioned, there's changes in the Department of Health and Social Care and NHS England, in ICBs. we're developing neighbourhoods and local government reform. So any plan that we have will need to be iterative. And, we may start with particular geographies, and we will work with local government to ensure that we try not to do anything that, won't make sense, depending on which local government reform plan goes ahead. But I think with any of these things, the plan needs to be iterative and will change. And what we submit in April will probably be very different to what we've learnt over the course of the coming year and the 5-year plan. And I think that we need to learn from, companies and be a bit more agile within the health service and be prepared to make changes as we go.
Thank you. I'm going to juggle questions in the chat with Olivia. Olivia, I'll just mention the questions now from the chat, and then we'll come on to you, and then they can be answered all at once, hopefully. One person's commented, what's the plan for improving health literacy for prevention? Another person's commented on the changes when we lost children centres, and that might be a chance to talk about the new family centres that have come in, and how can PPGs, individuals and leaders work with professionals to make significant and individualised changes. And then also a question about reach into rural areas and the use of community health workers. So we'll put them to one side. We'll go to Olivia, and then we could perhaps answer all the questions together. Olivia?
Thank you, Veronica. And mine are much along that track. It was around sort of the value of education, and within that Marmot driver. I just wonder if Ansaf has some reflections on that, because I know you're seeking to work with our colleagues in education. Sorry, I'm Olivia Clymer. I work at Oxford University Hospitals, and we very much welcome the work on this, and it's exciting, the opportunity for prevention. So it was that sort of educational element that links to the health literacy as well. Thank you.
Yeah, I mean, we so Olivia, you're in the steering group, so you would know some of the conversations that we're having. There is definitely, I mean, Marmot is the way the Marmot works. This is about actually how do we can empower each organizations to deliver Marmot in their own way, and actually improving health literacy in our community. If that's a priority, then I think there are key partners will have to play a vital role. So I think the community sector, the voluntary sector that are quite close to it can play a strong role, as well as our health partners like yourself, Olivia. So we can certainly pick up those conversations in the Marmot steering group. We've got 3 principles: best start in life, healthy standard of living, employment. We can look at through those lens. But health literacy is something, in a way, is absolutely relevant to neighbourhood health, because one of the things we want to do is to patients and residents to be able to look after themselves, to maintain that level of independence, and actually have a proportionate approach to how they use our healthcare system, in the sense that, so there are pharmacists who are very capable of helping patients to look after themselves. There are patients who are very much expert in their area of their long-term conditions, who's able to look after themselves. Now, those abilities is different in different areas and different community groups and so on, and that's where the inequality lens comes in. So I think absolutely Marmot could play a part in that, but there is also a role to be played in terms of all organizations who are involved in health literacy element, taking ownership. I don't know whether that answers the question, Olivia.
And the rural
absolutely focus. So the rural is a really good example. Thanks for reminding me that, Veronica. So for the 10 areas, we know the data. The data is out there, but we know in Oxfordshire that we've got some significant hidden inequalities we are not even measuring, and that's where the rural inequality comes in. And I think we might even be a bit of a blueprint to how we do that across the whole of the country, because rural inequality is an area that hasn't been really tackled as well as we would like to across the country. So we are doing all that, and with the expansion of the community profile approach across the county, all this will help to address those issues, Oliver.
So welcome that thoughtful challenge, Ansaf, because we could be built in from AUH with each of the clinics and the communications that we do. We could be endeavouring to do better at building in the reading attainment and making it more accessible. So thank you for that.
Thank you.
Brilliant.
I can see Tamer, you've got your hand up. Would you like to ask a question?
Hi, it's nice to meet you all. Well, it's nice to meet you all. Working in the community space within healthcare, I've come to see how co-production has grown over the past couple of years on all government levels. I think that something the community is starting to feel over recent times is that they're constantly being asked to participate in initiatives on a regular basis that don't necessarily deliver the visible impact that they're looking for. And that, in my opinion, leads to some what I would refer to as co-production fatigue, where there is a lower willingness for community members to want to engage even in the initial decision-making process of these co-production initiatives. So I guess my question would be, how do we deliver visible impact on a consistent basis in order to minimize this co-production fatigue? Because obviously in the long term, if they don't participate in co-production initiatives, that creates a new problem in itself.
Yeah, absolutely. That's what we do here. I wondered if Laura might like to come in and just talk a little bit about some of the examples where that has been changed through the initiatives.
Thanks, Veronica. Well, Taymor knows about some of the initiatives because he's part of the Well Together programme through Community First and that piece of work. But I think it's a really important point, and I think that at root, what we need to recognise, and I think that we are trying to recognise through things like the Marmot framework, is the huge amount of work that Oxfordshire's already done. And I think that goes back to Michelle's point as well, that actually we're not doing some of this stuff because we've been instructed to do it in this very rigid way. Some of the things that we're doing are things that Oxfordshire had already taken that decision as a partnership and system to tackle those inequalities. And so therefore we've got a huge amount of research already. And so we need to make sure that we're not just kind of putting one person's report on the shelf, but bringing everything into that web of knowledge that we've got about communities, and just make sure that we're feeding back to communities about the impact of what they've fed in to keep that relationship going, so that it's not a new consultation on a new initiative, but it's more about where we're planning to go in Oxfordshire over the next 10 years and what kind of vehicles we've got to do that. But I think, I don't know if others from our statutory authorities have got anything to add, but I do think it's an important reminder to not forget the huge amount of information that we've got from voluntary sector work, from communities themselves. We've got the community research network that has the potential to be really powerful, not just in terms of coordinating academic research that's taking place, but actually empowering communities that have been skilled up to drive the research that they want to focus on and deliver themselves. And I think it's about bringing in all of those aspects together.
Thank you. Sue, you've got a question.
It wasn't a question, actually. I was quite keen to respond to Tamar, if that's okay, on the back of what Laura said. So I can't work out how to lower my hand. There we go. So yeah, really sort of interesting question, Tamar. And obviously you've got, we haven't met. I work in Oxford Health as Director of Transformation, and supporting Michelle and Ansaf and others on this call in helping to coordinate and stand up neighbourhood health and care. I think you raised a really important question, just reflecting on it in terms of our work that we do in Oxford Health and more broadly around the neighbourhood agenda. As we start to work out what our sort of neighbourhood health and care planning geographies will look like for our populations, we will then, alongside that, as everybody's touched on, need to do that absolutely side by side, sort of communities, our staff and our other health and care professionals that may or may not be on this call. And there will need to be an element of prioritisation of sort of these, we acknowledge all of these issues and areas we want to address, but actually initially we're just going to sort of focus and address on these areas and then move to other areas. And I think that's going to be challenging for us to do in terms of sort of coming to that level of consensus of those areas we do want to focus on, because of course we'll want to focus on everything. But what we do know from some of the examples that have been shared on this call is that when we all do coalesce around a smaller number of particular initiatives and priorities, we know we can then see absolute tangible traction, and then we can move on and focus on to the next series. So I think that will also be an element of the work we will need to do over the next year as we start to work through, as Michelle and others have highlighted. This isn't something we're going to resolve in the next 12 months. This is, for the next 5 to 10 years. But really great question, and nice to meet you.
So I think one final question before we wrap up. There are more questions in the chat. What we'll do with those is we will add them to our website and perhaps get some answers to them, the ones that we haven't been able to come to. How can people get involved is the next question.
So a good question. I suppose the start of it is by having an awareness, coming to this webinar, so it's great. I know if people, we've now got coordinators based in each of the South, City, North and West. And if you wanted someone to come and talk to particular groups, I'm sure we can arrange that for you. Once we've organised the neighbourhood geographies, we will be looking to bring people together to have more local discussions. And certainly, as we, get more information about the direction of travel with the plan, really happy to come back and have a further discussion and hear your thoughts on the direction that we're going. The other thing we've done is we've already held 2 reference groups where we had input from voluntary care sector, GPs, patient participation groups, and also the other local providers. And we had some plan quite for the beginning of February, but we've had to review that in light of the documentation not coming. And we taking on board Tamir's point that we, are really clear that we don't want to waste people's time by gathering you all together, and we're not really having anything new to say. So we're planning on postponing those meetings until we've actually got the information that we can then have a more fruitful discussion about. I think it's really important to say Sue and I were both at a national neighbourhood meeting, and actually when we were asking about how people were engaging with local residents and the voluntary care sector, lots of people, we were quite far on in Oxfordshire in what we'd done. So we're hoping to continue that, and if you can help support us to do that, we're happy to take that on board as well. I can see Sue nodding.
Yeah, no, definitely, and I think in terms of, I think Veronica's just popped in the chat, happy to share the coordinator details. So I'm the coordinator for the North, so I'm happy to share the details for myself and the others. And also we can also then look perhaps through, Veronica, through your channel in terms of if there's anybody on this call that would like to come to a future reference group for the revised date that we're currently scheduling in April. Perhaps we can coordinate that through you as well, Veronica. That might be another helpful route.
Yeah.
Lovely, thank you.
Right, I think we need to draw it to a close. I think this is the start of many discussions going into the future, and it'd be great to revisit this in 6 months' time, perhaps, and also we'll get people involved via those pathways at the moment. But thank you so much, Michelle, Ansaf, Laura, and others for talking and coming here. It's a really exciting time, and I think it's a testament to the potential in Oxford and Oxfordshire. And as Laura says, there's a lot of work going on already, really great work that needs pulling together, and this provides that framework in lots of ways for us to do that. So the webinar will be on our website afterwards, along with the slides. So thank you everyone, have a good afternoon.